Hello, everyone. Also, welcome from my side. I'm again excited to have another webinar. Today, we plan to discuss three cases. We have, again, an exciting panel, and I hope we can really have a lively discussion. Please use the button so that you can also bring in your questions. At the time being, we do not yet have access to Laura from Argentina, but in the backstage, we are working on that. But having said that, we start with the first case, that's Josephine from Cleveland, please.
Hi, everyone. Thank you so much for having me today. I'm a bone and soft tissue pathologist from Cleveland Clinic. I specialize in bone and soft tissue pathology, and I also sign out molecular pathology as well. This is a case in a 24-year-old woman who presented with right shoulder pain for a couple of months. An X-ray showed that there's lytic lesion in the right proximal humerus adjacent to the greater tuberosity. An MRI was also performed, which revealed a 1.5 cm bone lesion associated with cortical thinning of the lateral aspect of the proximal humerus. There is some rim enhancement, but no internal signal, so the lesion appears to be a cystic lesion. A bone scan was also performed that revealed increased uptake at the same location at the right proximal humerus. So a CT-guided core needle biopsy was performed, which unfortunately did not show anything other than a blood clot, so that was not diagnostic. Because of that, an open biopsy was performed for the right proximal humerus, and the tissue was actually sent out for expert opinion, and it was diagnosed as an original bone cyst. So the patient received percutaneous treatment with doxycycline injection, and she actually reported improvement of her symptoms. However, after 11 months, the patient reported pain again at the shoulder. With whenever she's trying to abduct her shoulder, and the pain was also associated with forward flexion, and she also had some weakness at the location. So a repeat X-ray revealed this time a 2.9 cm bone lesion, again at the lateral aspect of the proximal humerus associated with cortical thinning. An MRI demonstrates a cystic multiloculated lesion in the right proximal humerus that also had an imaging characteristics that is consistent with an original bone cyst. So how would you want to proceed in this situation? Would you repeat doxycycline injection, or would you opt for open curettage and bone grafting? I welcome the audience to submit their opinion. You can either type it in the chat, or you can just unmute your mic and tell us what you think.
So maybe Michelle and Constantino, do you have any thoughts?
Yeah, I would curettage it, just because you've tried doxycycline and didn't work. So it's a tough location, but I do think that curettage would have the best chance of local control.
Yes, I agree, because it doesn't look like a typical aneurysmal bone cyst regarding the age and regarding the imaging. I'm not sure that this is an aneurysmal bone cyst. So I agree with Michelle that I prefer to have again another pathological analysis. And so, because the lesion is small, I would like to suggest a curettage.
So it's also my opinion. Our orthopedic surgeon, they prefer curettage and as a first line treatment.
Yeah, I do think you do need to confirm that it's not malignant. I know that sounds like it's unusual. But you don't know what it is. The bottom line is that you don't really know exactly what it is. So it might be better even just to biopsy it first, or do a curettage, but or at least do a frozen section and then complete a curettage if there's no evidence of malignancy.
That sounds great, and that's exactly what happened. The patient actually was the one who, so the surgeon offered these two options for the patient, and the patient really wants to opt for an open curettage, so that was what happened. And so this is the histology of this recurrence. So we see there's a lot of bone trabeculae, and then a lot of the fragments that has mixed with blood, and then this like fibrous septa with relatively bland spindle cells, some osteoclast-type giant cells that mix with it. So it does look, in many areas, look like an original bone cyst with all this fibrous septa with bland spindle cells surrounding blood-filled cystic spaces. And there's like some irregular redistributed giant cells and hemosiderin deposition. So most of the tissue actually look like this, and it looked consistent with an erosional bone cyst. However, focally, there are areas with these polygonal cells with pretty well demarcated cell borders, and the nuclei are irregular and reniform to ovoid. Some of them even show nuclear grooves, and again, it's mixed with multinucleated giant cells. And there are areas where there's this pink chondroid matrix, and as you can see, we actually performed immunohistochemistry for histone H3K36M and also G34W as well. It's mainly because of the patient's age, and more importantly, the epiphyseal location. We want to make sure this is not a chondroblastoma or giant cell tumor with secondary ABC. And so the K36M nicely stains the mononuclear cells with the nuclear expression, and the giant cells in the background are negative for the K36M. So confirming that this is actually a chondroblastoma all along with secondary ABC-like changes. And so as you are all aware, there's driver mutations in the H3F3A and H3F3B genes discovered in chondroblastoma and giant cell tumor of bone that are actually oncogenic driver mutations. And subsequently, antibodies specific to these two mutations, G34W and K36M, has been developed and has been proven to be a very sensitive and specific marker for the diagnosis of chondroblastoma and giant cell tumor of bone, respectively. And so in this case, I agree with everyone. And chondroblastoma is actually one of the bone tumors that most commonly presents with secondary and original bone cyst-like changes. And if the tissue that is sampled only reveals ABC-like areas, it's very easy to call it an ABC, a primary ABC. And so as pathologists, we have to maintain a high index of suspicion and always correlate with radiology. In this case, we actually, when we were reviewing the case with the musculoskeletal radiologist, he didn't identify any areas that look like chondroblastoma or giant cell tumor of bone, but we realized that it is a lesion that is centered in the epiphysis. And so we were like, oh, we should probably perform the histone markers. And lo and behold, we found that focal area that actually is the chondroblastoma area. And so having this awareness and close correlation with radiology and using tools that are good histochemical markers that can be a surrogate for molecular alterations, like the histone markers, can be very useful for diagnosis. So that is all I have for my case. If anyone has any additional comments or input in how you typically manage these cases, that would be great for discussion.
Thank you so much, Josephine. Really interesting. I think it would be great to hear Gunhild's view and how she sees this from her perspective. Gunhild, can you hear us? You are here.
Well, I can hear you. Can you hear me as well?
All fine.
Okay, so I was just a little bit out of context because I got an email to switch on Zoom app. So if I have well understood, Josephine, you presented a case of chondroblastoma with secondary ABC-like changes. So and it was positive for the mutation marker, isn't it? Okay. So I would say ABC and other giant cell tumors, from my point of view, belong to the most difficult cases in bone pathology, because whenever I see cystic areas, as you showed, I'm always a little bit saying I'm afraid to oversee an osteosarcoma, a telangiectatic one. But finally, I think there were not so good solid tumor areas, isn't it? So it's, I think in these cases it's very difficult, but it was located in the epiphysis. It was a young patient. So I think if you think on a chondroblastoma, you should just do the analysis you did, and then you should get the diagnosis. But it's a difficult diagnosis, I think.
Yes, actually like more than 95% of the region is just purely cystic tubular tissue, and we actually didn't identify those areas that is the chondroblastoma area until after we did the IHC, and then we went back and looked at H&E, and oh, actually those areas in hindsight we realized that it's actually the chondroblastoma that is like the small areas. So yeah, I agree completely. It really is maintaining a high index of suspicion, because sometimes the histology really it's like overwhelmingly just look like a cystic lesion, look like an ABC, and the areas that are that corresponds to chondroblastoma or the giant cell tumor of bone, really they may not stand out just on H&E.
Yeah, thank you.
That's a very nice case. Again, I think it underscores the importance of the imaging for the bone and soft tissue sarcoma pathologist. I think the age and the location near the growth plate, I think, were helpful in leading you to the diagnosis. And a very nice work. Thank you.
Maybe if we have, let's say, you here, how do you judge the metastatic risk? I know it was downstaged, but again, it happens. So what's the pathologist's perspective on this?
Typically, chondroblastoma is considered for us a benign bone tumor. There are very rare cases of malignant chondroblastoma where the characteristic features may not be present, and they often occur also in unusual locations, not necessarily near the growth plate, and also could be in older individuals. In those cases of malignant chondroblastoma, it's a very, very challenging diagnosis, and often they uncovered by performing the histone marker immunohistochemistry. But it would be one of those cases where if you don't see any conventional areas of chondroblastoma and you don't think about it, it's almost like an impossible diagnosis. But for the vast majority of chondroblastoma, we tend to think about them as benign bone tumors that may have locally recurrent potential, but not necessarily metastatic potential. I wonder if anyone else has other input on this.
Regarding the location, Michelle and Costantino, do you have any special thoughts how to approach, maybe even in a growing skeleton, the epiphyseal lesion?
Yeah.
You go ahead first.
Me?
Yes,
you first.
No.
It's a pleasure to see you.
I spoke first last time. It's your turn.
I think that in this case, you can see that fluid levels in a wide variety of bone tumors, and in this case, the most important data was the location and the age. So it was epiphyseal lesion in a 24 years old girl. So the chondroblastoma fits in a case like this. Regarding the surgical approach, I know in a proximal humerus, we also do an anterior approach. So the anterior approach, I think, is the best way to do it, because you can rotate the humerus in the operating room, so you can go everywhere in the head of the humerus and doing a curettage. In the past, in other locations, such as the proximal femur or distal femur, but I think the proximal femur is the most challenging location for the chondroblastoma. I mean, regarding the surgical approach to avoid, problems to the patients, you can do endoscopic curettage that was published, I think, more than 15, 20 years ago. And I made this kind of surgery in a few patients, avoiding to open the joint and do a tunnel. And then, and I publish a case report like this. So it's a benign tumor. You have to do a curettage, so it's not so difficult surgery. So, or standard approach, open the joint, or if you want to try to do something different and be less invasive, you can do an endoscopic curettage, but not inside the joint, but extra-articular curettage using an endoscope, doing a tunnel, and then doing a curettage.
Yeah, no, I agree. The epiphyseal lesions are really difficult. Usually these aren't large lesions. They're right next to the physis, and they're in the epiphysis, so they're right next to the joint. So they're not easy locations. I haven't done endoscopic, but I've done fluoroscopic guided, intraosseous drilling to the lesion and curettage through fluoroscopic guidance. I've done that in the femoral head and in the humeral head as well in a child. But I think she's 24 years old. I think, and this is subchondral. So I think you're right at the surface. So I think a delta pectoral approach is as small as you could do, and rotate the humerus so you're looking right at it, and then that's probably would be the most effective in this specific case. But I agree with you. You don't have to open these, and if you do, you're looking at the joint. So generally, you try not to. So like a intraosseous, minimally invasive approach is really reasonable. These are not biologically aggressive tumors in general, so you can do that kind of curettage. But
in this case, we needed a diagnosis. Mm-hmm. So I think that an open approach was mandatory, right?
Absolutely. It was weird. Yeah, it was weird. It didn't make any sense. Epiphyseal and 24 years old, it didn't make sense for an ABC.
Yeah.
You don't want to be that surgeon. Yeah. You don't want to be the surgeon that curetages a telangiectatic osteosarc, right? You don't want to be that surgeon.
So there are questions from the audience. Ashik Barry says, does your curettage principles change if it's a chondroblastoma versus GCT? What do you think?
You first?
Yeah, I'll go first this time. I'm less aggressive with chondroblastoma. GCT is, it's if you don't get every little itty bitty tiny little piece of every cell out, it's going to recur. But chondroblastoma, I find, at least in my experience, is more forgiving. I find it a little more forgiving, so I'm not as aggressive.
I agree. You don't need to be so aggressive. So yeah, just curettage and filling the cavity with bone chips, and that's it.
There are questions and comments from John Healy. Maybe Shannon, can you see whether you can unmute John Healy so that he can discuss with us too? But I can start just what he wrote. The epiphyseal location classic for Crodman tumors, such as this from the beginning, an injection was not the suitable treatment. Interestingly, there is less edema in the marrow than usual. And then 1 to 2% metastatic potential that should be followed with X-ray. And another interesting comment from him was reinforcement of supraspinatus tendon insertion is often needed. That arthroscopy has the potential to spread the tumor. Thermal ablation might work. Any comments on this from your side?
No, I've done all of these things, including spreading the tumor and metastasizing the tumor. So, getting the diagnosis correct from the beginning is important. I think she's a little bit old for this diagnosis. There was less edema in the marrow space, so that it was not the classic, despite the location in the apophysis. And so I would have opened it from the beginning and done it in a controlled fashion.
I think this is certainly not wrong, right?
That's just one person's view.
Exactly. Well, no, absolutely. Yeah. That's awesome. Any other comment? Well, John, thanks so much for joining us ad hoc. That's awesome. Any other comments?
No, I just want to say hello to John Healy. That was my mentor more than 10 years ago. So,
hello, Constantino. You've excelled past the mentor. That's all I can say.
No.
That's so nice. That's awesome to reunite just like this. So then I suggest that because Alex Lazarides from Tampa only can join us in the next few minutes.
Well, thanks for letting me talk today. My name is Alex Lazarides. I'm one of the doctors, orthopedic oncologist down here at Moffitt Cancer Center in Tampa, Florida. And I always love these meetings. It's great to hear from everybody, and it was great to catch up with everybody at CTOS a few weeks ago. So today we're going to talk about a case of osteosarcoma with the disease progression on chemotherapy, which we actually heard a very timely discussion on at CTOS. So I don't have any relevant disclosures, so we'll jump right into it. It's a 26-year-old male presented with right hip pain, and it started after an injury while getting up from a couch about 4 to 5 months prior to his presentation, but the pain never went away and continued to progress until he began to have persistent groin pain and persistent difficulty with ambulating and weight bearing. He has no other relevant past medical history, and when we saw him, his exam was notable for pain with hip range of motion, pain with strength testing, all localizing to the hips. He was otherwise neurovascularly intact, and so this is what his initial x-rays looked like. So I don't know who of the panelists we have on the line, but does anybody want to take a look at this and notice anything in the right hip of concern or not concern?
Well, maybe we just have to go ahead and
Perfect.
The little changes.
Even better. So if you look at the right hip joint, the right proximal femur, you notice that there's an area of subtle sclerosis here in the femoral head. And if you really zoomed in, it's hard to tell here, but maybe the most subtle of cortical changes here along the inferior margin, but pretty subtle. So obviously we proceeded with an MRI. And what you'll notice here is that looks like there is a joint effusion, some areas of sclerosis extending throughout an edema extending throughout the femoral neck and head, and then clearly an extraosseous soft tissue mass or extension beyond the bone there. So this patient has pain. He's got a bone lesion, intra-articular in location. There's extraosseous extension. So just the question for the panel, if anybody's interested in trying to answer, the question is how would everybody proceed? And we entertained all these options. So I'm curious what everybody would pursue. So would you open biopsy? Would you go with an image guided biopsy, a core needle biopsy, or would you say, listen, he's having pain that looks concerning, avoid a biopsy altogether, let's go to surgery?
Maybe
hey, Alex,
yes, please, Michelle.
Yeah, just show the image again, please. MRI.
Yeah. So the lesion is the primary soft tissue component is located kind of posterior-inferior in the femoral head, basically. So tough location. And if you kind of look at the cross-sectional views as well, you can see that difficult location. So it's almost, just on the other side of the acetabular rim.
I would go transtrochanteric probably. I would do open. And get a frozen, make sure you got tissue. I don't know. There's no good answer for this because you don't really want to open the joint, but it's already in the joint. But at the same time, I don't know. When I biopsy femoral heads, I usually go transtrochanteric. That way you don't you don't further violate the joint.
Yeah, I 100% agree. We entertained all of these options. You know, we had some of my partners said, listen, this looks like it's behaving, suspiciously. It's not going to change the nature of the surgery I would ultimately do. Take the whole thing out, and there was a lot of debate as to whether this was truly contaminated in the joint or not. But they said, hey, one option, we just take it out, then you get your pathology and you treated it. Other people said, well, it's already in the joint, just do a core needle biopsy. But I was of the same mind as you, Michelle. I said, listen, I'd rather do the most conservative thing. Let's do a transstroke enteric biopsy, confirm that we have adequate tissue for making a diagnosis. And so that's what we proceeded with. We did an open biopsy, transstroke enteric approach, drilled through and confirmed under floor that we're in the right spot, and sampled this area and found ultimately this was high-grade conventional osteosarcoma. So I apologize as I don't have any slides to show you the pathology, but really the only relevant.
Sorry, so you mean that you did a lateral approach or anterior approach?
We did a lateral approach, yep.
Lateral approach.
And made a window just below vastus ridge, small hole there, and drilled a hole through the femoral neck and to access this lesion. But it's a very challenging place to access, because you're drilling through the entire intertrochanteric region and then the femoral neck just to access the area that seems mainly involved. But we felt like that was probably our best bet of making sure that we actually got into the right spot. But amongst even our partners here, we had a lot of debate as to what the appropriate course was moving forward. So confirmed to be high-grade conventional osteosarcoma, and got the routine staging, which would indicate that this was localized disease. So the question for the group then is, how would everybody proceed? It's obviously a relatively confined small lesion. You say, well, let's just get this thing out and then get them to chemo, do more of a standard approach. Any other considerations? I imagine there's probably not too much debate about this, but.
May I say, as a pediatrician, I'm here in Olga Hospital, and Stefan Bilak was here for decades, and of course in our hospital it would be chemotherapy with MAP at the beginning and then surgery.
Yeah, I think that's pretty standardized at probably most places at this juncture. So, we were of the same mind, let's go ahead, proceed with a standard regimen of MAP, chemo, 2 cycles, restage, and then surgery. And at that juncture, our kind of thought process was, well, and should not compromise the nature of the surgery one way or the other, and kind of let the tumor biology declare itself. So he, when he was getting chemotherapy, he said that every time he got the chemo, he felt a lot better. Then his pain would kind of return a little bit until he got into his next cycle. Then it would get better. And so we repeated his chest staging. That was negative. And then this is just a comparison of before versus after. So you can see our biopsy tract that we ended up. We kind of did more of an anterior to posterior trajectory. But you can see even on that post image, when we reevaluated him in our clinic after 2 cycles, certainly a lot more sclerosis going on in here in the femoral head, and a little bit more, concerning density here. But that didn't really tell the full story until we got to the MRI. So now he's had just an explosion of disease in his hip, unfortunately. There's evidence of erosion into the acetabulum, and pretty much circumferential disease. So I'll just play it one more time. But certainly has let the disease declare itself, unfortunately. So he's had disease progression on 2 cycles of chemotherapy, and he's a pretty stoic individual, and really didn't communicate that he was having more pain or anything like that. But unfortunately, you can see this here. So let's go to the next question. So the question is, he's 2.5 or 3 weeks from surgery. He's got disease progression with evidence of acetabular invasion. So the question is, how do we proceed? This is clearly acting as a bad actor. So would the panel continue to work with limb salvage surgery still? Would you say, well, this is bad biology, this needs to go to an amputation, maybe consider some alternate approaches? And again, in our mind, we were thinking, well, at the worst, we'd have to do an extra-articular with off-the-shelf implants, but it looked like there was extension of the disease about 1 to 2 centimeters above the acetabular dome. So that made us think that this was going to be more of a true formal type 2 resection if we did a limb salvage approach. So then you ask the question, well, how do you reconstruct with only 2 or 3 weeks left until your surgery?
Alex, has he been restaged in terms of chest CT?
Yeah, we restaged him and everything was negative. So this was still localized, even though he had disease progression.
Hey, Alex, it looks like there's edema crawling up the iliacus. Can you show the MRI again?
Yeah, there's a lot of edema.
Is it going
And
all the way to the SI joint? It looks like, oh God. Yeah. Like, I don't think you can go with the type 2 there because you don't really, you need to get like, yeah, you can't just go with type 2.
Yeah, and admittedly, these are the T2 weighted images. So he had a bunch of edema that did extend, you know, into the kind of the obturator foramen region. He had edema that looked like it was extending along iliopsoas. You know, we did a lot of scrutinizing of these images and with kind of the contrast weighted views. And so I agree. There's a lot of question marks with this case for sure. It seemed like the main soft tissue component was confined periarticular, but we were concerned about some of these changes along the obturator ring and extending along iliopsoas.
May I have a question? Have you compared the MRI after the open biopsy before chemotherapy with the MRI now after 2 cycles?
Yeah, that's a great question. So the MRI was from pre-biopsy. I will say that we did proceed fairly quickly from that MRI to the open biopsy. But to your point, I don't have off the top of my head how much time transpired between, you know, when that initial MRI was done versus when he started chemo versus when he had his repeat staging. Because that was one of the other things is that we talked to the patient. We said, listen, we don't know if your disease just exploded and was progressing before you started chemo, or if this truly disease progression on chemo. We were a little bit suspicious about the fact that, you know, that he was having kind of persistent pain. Yeah, I think that that's certainly a valid point.
Another issue is which is your preferred sequence to base your resection level on? I mean, that's an open question to everyone.
Yeah,
I mean, how do you judge the tumor extension? Or edema, well, we assume it could be, but
yeah, the worst one, the one that has the worst extent of disease, that's what I go with.
We tend to use a combination of the contrast weighted views and T1 to kind of define the anatomy, but I think that to Michelle's point, it's kind of, you know, it's a conglomerate of all the imaging modalities, and I think everything has a role to be played. And so anyway, I think the question of, you know, all of these things were things that we considered, and ultimately our decision was made on a combination of our radiologists do a lot of kind of subtraction sequences and DWI sequences that they feel helps them to better delineate what's tumor versus what's edema. They're still studying that, but a lot of these decisions we make in concert with our radiologists for sure.
So, no, I think it just shows the challenge, right? Another question, John Healy brought up another question. Janine, please bring him back. I think you muted him again. He asked the question, did you cement the biopsy tract?
Yeah, we did cement the biopsy tract. Yeah, so once we did the biopsy, we put cement in. I can show just the images here, but this is our cement here, our cement plug that we put in here. And we try to leave a little bit proud there so we could feel something or knew what we were taking out if we had to go back and excise we plan to excise the biopsy tract. But yeah, we did put cement in.
it looks like you pressurize the cement. And so I think that's something to just be very careful about. And especially when it's already arguably broken through the cortex and that inferior area. And so some of it may have been contributed by overzealous cement packing through that area. Yeah. And, but I understand. And so going, laterally and through the greater trochanter, you're going through the only normal bone around there and weakening it. And so you would like to reinforce it. I get that aspect, but that's why I think, and since it was already contaminated in the joint, an anterior needle might have avoided some of those things. But
yeah, and I do wonder
that's
if the
2020 hindsight. Yeah.
Exactly. I do wonder if the open biopsy exacerbated things or made anything worse. But to your point, we did think about that. So part of what we try to do is put a little bone wax in here. And so that way, when we were putting the cement in, it was hopefully only pressurizing this area here. But to your point, it's impossible to, fully control those variables. But we ended up having a long conversation with this patient about all the options and discussing all of these courses. And he's a pretty active individual. And I think, a lot of people would say, listen, this is aggressive biology. If you are going to proceed with limb salvage surgery, don't resect it, give him every opportunity to get back on chemo with the minimal risk. We did discuss that with him at length. We'd also discussed amputation, which he said was not on the table for him. And so ultimately he said, listen, I want limb salvage surgery. I understand the risk inherent. I'm interested in a reconstruction. And so either way, I brought up this point. I think that there's a lot of debate about reconstructing or not reconstructing, especially in a very select circumstance like this where there's disease progression. And so, despite the debate, I think the most important thing is to acknowledge that with reconstruction, there's certainly a higher risk of complications overall. And ultimately, the most important thing is to make sure that you're having an informed conversation with the patient. So I'll just go, for the sake of time, go through what we did. We had 2 weeks. We were weighing our options. And the fact that the patient wished for a reconstruction, and ultimately, had a lot of input from my partners, but we went with the Lumic cup. We did an extra-articular type resection for this patient, and did a type 2 resection. We implanted the Lumic cup, which was a press fit construct, and then cemented in the proximal femur for kind of a hybrid construct. And our margins ultimately were negative. The closest was 2 millimeters in kind of the posterior soft tissues, but you can see that the tumor necrosis was 40%. So I'm sure we could spend a lot of time debating on the right approach here. And I think, it's a tough decision. This is a tough case. Any comments on this?
Do you have any follow-up on that? Or is that recent, Alex?
Yeah, we have I'll get to that here. So this is just some intra-operative group. So you can see extra-articular resection here. And there's the Lumic cup with the pin going up. And then we did a cemented stem on the other side. It's a dual mobility kind of construct, and has a kind of a little aortograph type mesh that goes over the top to add stability. Because of where the tumor was, we were actually able to save a lot of the soft tissue. And so my question then for the group is, all right, so you're here you are now. Now what are you going to do? Just give me 30 seconds. I'll be right back. But pontificate on that.
Yeah, may I comment? The role of the adjuvant chemotherapy in osteosarcoma, especially if it is true non-response, is really controversial. so the Stefan Bilak recommended always some kind of chemotherapy, even in the case of non-response, second line, and so on. But you know that there is no evidence that such a therapy really improved the prognosis. But probably my feeling, I would give the second line chemotherapy with EA or carboether. There are two combination which that are recommended by Sarcoma study. So I think that perhaps it will help, but there is no really evidence for it.
Is there anyone who would categorically not do any chemotherapy in such a situation?
Our strong belief amongst our group is that chemotherapy is absolutely the most important thing. And so I bring this point up a little bit later, but I think that you know, there's to the points that have been raised, there's a lot of data that, you know, would say that changing the chemotherapy regimen based on percent necrosis, you know, there's a good study out of MSKCC initially that suggested good results, but a lot of the follow-up studies have not necessarily supported that. And some of these larger collaborations like the COG and the Erasmus studies have said that there really isn't any benefit to addition of any additional agents or changing the regimen. But I think that uniformly what is agreed is that chemotherapy is better than not chemotherapy. And the patients that can't get a full chemotherapy regimen certainly do worse than the ones that can.
Which speaks in favor of
the switching of chemotherapy and what was originally reported in T10 and others, you know, that didn't add platinum till later. So it's quite different than what the COG randomized trial showed. And so, you know, but very nice surgery. That you got a margin is great. You have to be careful about disease tracking up the psoas bursa and getting it intrapelvically, for example. You know, I think the concern is what you know, the Rizzoli and Picci's work, and to more recent degree, Lee Jay's, and looking at the margin issues, and with only 40% necrosis, the risk of recurrence goes up dramatically. So it's not just the systemic benefit, which is huge and life-saving, of course, but it's also local control, as their studies point out. You know, 7 times the local recurrence rate based on poor chemo response preoperatively with their studies. So, you know, if you're not going to give chemotherapy, to answer the other question, I would go very wide and even amputate. You have to depend on some effective chemotherapy. In the COG study we did with MTP, the IFOS and MTP combination actually did the best, even though IFOS alone did worse. So it was a divergent response. So, you know, pay your money and take your choice. Yes.
No, and I think to your point, you know, there's been a lot of interesting study in, you know, the Birmingham study, which suggests that for local recurrence in particular, it's a combination of percent necrosis and your margins that definitely matter. And I totally agree. I think in a circumstance like this, where typically you're relying on you know, some response from chemotherapy, I think that the way you plan your surgery matters even more so. And I'll tell you, we spent a lot of hours talking with the patients and the families, and I spent a lot of hours getting gray hairs thinking about this case. But you know, ultimately, you know, this patient's 6 months post-op now. He has no evidence of disease. We discussed his case at length with our tumor board, and you know, we had a lot of divergence of opinions, but ultimately medical oncology felt like the best route was to proceed with MAP chemotherapy. without changing the regimen at all. We did not do any additional radiotherapy, and he's now ambulating independently. He has no pain, and we'll just have to wait and see, what shows. I will say that we did have one surveillance scan that was concerning. We got the post-op scans, we biopsied a nodule, everything came back negative, and it's been totally stable since. It seems like it's probably just heterotopic changes, but I'm pretty new into practice, only a couple of years now, and these are just the amount of decision making that goes into these cases is quite exceptional. I think this is just from Up to Date, which is some very, very interesting information, but it kind of reflects all the same things that we said. That really is that, I think the big point is the point at the end, that even in the less favorable setting, patients who receive chemotherapy have a better outcome than those who not. And that there's not really good evidence that would suggest that changing your regimen does or does not necessarily affect it. I think that's the benefit of a tumor board discussion and making decisions on a case-by-case basis. So I think, disease progression on chemotherapy is rare. I think in the COG study that they presented, it was 55 patients out of thousands that had disease progression on chemo. But it obviously portends bad disease biology. Overall, the survival for that group that they quoted, I think, was about 40 to 50%. But the big takeaway that they elaborated was that despite this, that's 40 to 50% of patients that will still have a favorable outcome. You should still treat them. And while, it is a bad actor, and you can make a lot of debate about how you should change the treatment due to that, the reality is that standard of care treatment can still provide benefit for a good number of patients. So appreciate everybody's attention, and very interesting to hear everybody's inputs. I don't know if anybody else has any additional thoughts or comments.
Alexander, fascinating case. Thanks so much for sharing this really challenging decision-making process, and we all struggle, I think, with the same thing. I want to just ask Tom and or Gabby about your thoughts on radiation. We said we didn't do in this case. What are your thoughts on this?
My indication, Bruno, has usually been a positive margin. Occasionally patients with a nasty pathologic fracture. I've radiated as well in the setting of a poor chemo response, but I think if the surgical margins here were negative, I wouldn't add radiation, and I think that the highest risk is probably systemic. One other comment, actually, a patient I actually shared with John Healy, a young man who had a radiation-associated sarcoma. He had asked me if it were me what I would do in terms of additional treatments, and John had brought up the myramyl tripeptide, the MTP, which is when you look at that study, there was actually a trend towards benefit with the MTP, and this patient decided he would go ahead with that, and he actually went down to Mexico just to pick up the drug, and it was administered in the States, and he remains disease-free, and he had a very nasty radiation-associated osteosarcoma.
Awesome.
Thank you for sharing that, Tom.
Maybe another, also going back to Gunhild and Josephine, is there anything on the horizon that you can pick up these bad responders?
Which response?
There's an echo. Well, I just know, is there anything on the horizon diagnostically to sort out or to identify the bad responders?
As far as I know, no. We should ask Eva Kosiniak, but I think from the morphological point of view, from the genetic data, you can't predict it.
Well, Eva, you are now on the spot. Yeah, I want to hear your comments now.
Because of this echo, because the Professor Mechtersheim is logged twice, and for this reason, she should just log out one. If you look, she logged twice, and in such cases you get such echo. But could you repeat the question? I have not understood what she
She asked, well, she brought up whether, from your perspective, you have any insights how we could identify the bad responders early on.
That what?
The bad respond, I mean, chemo, osteosarcoma patients.
Yeah, I understand, but what did she mind with this bad response? Because it is, of course, the bad response is, as the colleague said, is associated with the poor prognosis, and the role of the additional chemotherapy is they were studied also for the GPOH group. But there was not really showed that the change of the chemotherapy or the change of the chemotherapy will improve the prognosis. Perhaps even if the because you cannot investigate it histologically anymore after resection and poor response. So it's still this question with poor response and additional chemotherapy is, I think, controversial.
Thank you so much. Constantino, you have a question?
Yeah, just two comments. Campanacci used to say that the biopsy is the most important step in treatment of bone tumors. So in a case like this, maybe trocar biopsy was a better way to avoid contamination of the joint. And in case of open biopsy, we don't suggest to use cement. And in a case like this, if you use too much cement, you can, increase the pressure inside a small tunnel and maybe spread the tumor inside the joint. So this is my first comment. The second comment is that Campanacci used to say that if you remove a chemosensitive osteosarcoma, you can stay very, very close, such as in exostosis. So you can stay very, very, very close. But even a chemo-resistant osteosarcoma, it's better to stay far from the tumor. So it was a great surgery, great reconstruction, but maybe an external hemipelvectomy was the safer to have
safer bet. Yeah.
Wider margins and avoid the risk of local recurrence.
Thanks so much. Tom?
Well, I think John Healy had his hand up first, if John wants to go.
All right. Well, two points. We are using PET scan increasingly to look for a reduction in the SUV as another indicator of response to therapy in a non-invasive way. But back on the histopathology, what we did with Rich Gorlick and Joe Bertino, identifying that methotrexate requires a reduced folate carrier to get into the cell. And only half of the osteosarcomas have that. And so, in other words, half of them don't have a chance to really respond very well to even high-dose methotrexate. And so that partly accounts for the T10 benefit of changing therapy, because some of those people, they had just methotrexate to begin with, and then you switched over to effective chemo post-op. And so so all of those studies need to be remembered in context. And I wish we had reduced folate carrier bioassay as an indicator whether to be using methotrexate, which is difficult to use for a variety of logistical reasons in different centers. But they were just my comments.
Great. Tom?
Thank you, John. My only comment is really just one of the challenges we face as oncologists. I think this is one of the more difficult challenges we face in a young patient who's had a poor response to chemotherapy. Every young patient I know I've ever treated wants to beat their cancer, and they'll tell you they want to beat their cancer, and you're sitting opposite them, knowing if they have this kind of histologic response that they're likely to have a poor outcome. And from my point of view as an oncologist, I think I find that one of the most difficult challenges we face to support these patients going forward, because they likely are going to recur.
Thank you, Michelle.
Yeah, hi, Alex. I think it's an amazing case for discussion in every angle. And you know, obviously your surgery went extremely well and he's doing great. It's just, you know, those of us who've been in practice close to 2 decades, I know this is not going to work out well. It's going to work out badly surgically. It's going to work out badly oncologically. I think in these situations, all you can do is try to give them hope and give not false hope, but give them something to focus on. You know, is it recovery from surgery? Is it, you know, what do you want to do in your life? If it's more, I don't know, like if we go all out and give them, you know, this huge surgery and then all this chemo, that's fine because you want to save them. They're 26 years old. But at the same time, you got to balance somehow that you want this kid to be in the hospital for the rest of his life. And how much of his life do you want him out of the hospital and enjoying his life? And can you maximize that? And I don't know the answer to that, but it's something you grapple with in these cases.
Yeah, I think you all are hitting on excellent points. And so that's why I pulled in 2 of my partners to have separate discussions with this patient and help us have that counseling and make those decisions together. You know, I think these are all things that you try and think about early in practice, but it's just, like I said from the beginning, it's just such a complex situation that to hit on everything, you know, despite multiple conversations is challenging. And I think we as physicians, it's probably impossible for us to fully convey to these patients, this is what we feel and think is going on with your case. And so I think it is a tough conversation to have an informed discussion with a patient who's 26 years old in this situation.
Yeah, it's brutal. But you did a great job, and I hope I'm wrong and it turns out well.
Absolutely. Maybe very last question. Would anyone, as John brought up, in retrospect, now do an amputation, an external hemipterectomy?
If instead of that, I would have just continued with palliative chemo. It's a palliative situation. I would have just continued with palliative chemo. Hindquarter is just it's too morbid for a young person, and you know you're not going to save them. So I think either doing, you know, the hero step that Alex did, or you just say, you know, you want to be out of the hospital for the rest of your life, come in and get some chemo and day clinic chemo and go live your life. Keep his pain under control. That would be my amputation of sorts, my salvage approach.
Yes.
Yeah, I support it, Bruno. It's a very, very good point. I think that I would support that. I will give some kind of chemotherapy, as for instance the ifosfamide, eto, something like that. You can give on the day clinic base, and because MAP chemotherapy is quite hard for the patients and also associated with a high rate of toxicities. And so I absolutely support this opinion.
Awesome. Any other comments?
I'll share one thing, which is not in the literature, but Ralph Markov used to then give metromic Cytoxan to the patients, and so they got supplemental chemotherapy for a year afterwards. And in his clinic, I used to write those prescriptions, and so I'm quite familiar with it, but that's not in any of the publications. And so there's a whole other element to this to consider. And the final thing philosophically is, I think that what has stood the test of time for me is what Jerry Rosen taught me, which was to start off by defining what is the best curative option for this patient, whatever that is. And then based on certain personal issues or other features, you may back down from that. The dilemma is that all too often we start and go the other way. Say, what's the least we can do to get away with and still solve this problem? And so there remains a role for amputation. And of course, not too many people are coming in asking for amputation. So it requires careful discussion and guidance to come to that conclusion. But anyway, thank you.
Point. Well, I'm just grateful. First, of course, for the speakers. You did an amazing job. You had absolutely great cases. Unfortunately, it did not work out with Laura, but thanks to Alexander and Josephine, we had great discussions. And of course, this goes on with a great panel and with your participation and sharing your experience from all sides and angles from the globe. I think it's just fascinating. I'm thrilled. I learned again a lot. I want to thank you for your time and your efforts to participate and share. And I'm looking forward to see you soon again next month.